Yeah, thank you for the question about telehealth and the future of telehealth as it relates to the payer relationship. So, telehealth has been a lifesaver for us and our patients as far as allowing us to maintain access to care, especially in the first wave and second wave, March, April, and then July here in Florida. And unfortunately, it looks like it's going to happen again sometime in December here in the South. So it is, again, alleviates a lot of the stress because patients don't have to necessarily come to the clinic. And a lot of times we're able to do telehealth visits. Uh, uh, Number two, I think telehealth is an incredible tool for value. A lot of times patients who don't feel that they have the proper access to care end up showing up in the emergency department or urgent care just because of a simple question or something that could be uh, handled pretty quickly with a face-to-face electronic visit. And you know what happens when they show up in the emergency room or urgent care. There's at least 50 to 70% chance they'll get admitted and then stay in the hospital, undergo unnecessary tests, very expensive, potential exposure. So I think telehealth should continue not only during COVID-19, uh, which is a must just to prevent more complications of COVID exposure, but also in the future. I don't think anybody wants to go back to the past pre-telehealth. Um, at Florida Cancer Specialists, when we turned on telehealth, the first few days, the uptake was relatively small because we're training our physicians, but within a matter of a week, we had 25% of all encounters done via telehealth. This was in March, April, and then it has come down to 15 and then 10%. Our average is about 10% at this point. So telehealth is not like a panacea that will replace interaction with our patients, but I think is adjunctive as far as access to care. I think the steady state will be anywhere from 10, 15% of telehealth in the future. Yes, unfortunately, any stresses to healthcare or social or economic uh, uh, areas in life will cause exacerbation of the disparities, right? So we unfortunately know that individuals who are quote unquote socially challenged from access to care, access to proper preventive treatments and actual treatments, they do worse from a clinical standpoint in a vast number of disease process, diabetes, heart, cancer, COPD, and others. And there's this electronic challenge. A lot of us as Americans, especially in rural areas, and some of us of more advanced age, may have trouble connecting with internet or having fast speed connections to allow us to do video exchanges. So it has exacerbated the disparity for sure. So until we have global fast access or 5G technology that's spread in the country in a uniform and normalized fashion, we'll continue to see issues related to telehealth inefficiencies to some extent. Yeah, so I hope our colleagues in the payer industry will continue to be flexible as they have. Again, I must emphasize how well we have worked together in general, especially as it pertains to telehealth and maintaining uh, uh, the revenue cycle operating well as far as payment for procedures and value-based operations as well. So kudos to our payers that have worked with us fairly well. One thing that could be improved is prior authorization. Again, there's a tremendous amount of wastage in prior authorization by payers. And it's estimated that a regular physician spends anywhere from 15 to 20 hours in prior authorization processes per week. The national cost of prior authorization is in the order of $30 billion per year. And you're not going to find any doctors or patients who will say that prior authorization improve quality of care, access, or outcomes. It can't happen. So I understand why it exists, but I also don't understand why it exists, because it doesn't add value to the whole equation of our healthcare delivery system. So I hope our payers take away from our presentation and others that telehealth should stay and be viable. That they don't omit payment or decrease payment for telehealth or electronic exchanges significantly. Otherwise, we'll go back to square one. Again, telehealth, in my opinion, and other colleagues, is a very strong value-based tool and should be continue to be implemented and expanded nationwide. Yes, great question about the timing of implementation of new methodologies of payment. I am fully behind value-based care initiatives. As you may know, Florida Cancer Specialists is probably the largest OCM practice in the country, and we are on two-sided risk, and we have done very well. And we are also doing value-based contracts with several large commercial payers in the country, and successfully to a significant extent. But during COVID-19, it's really a bad time to do new models, experimenting or pushing the envelope too quick, too hard, because it's just we are under a tremendous amount of stress, and none of us wants to fail and not deliver and have consequences in terms of two-sided risk for our practices that could impact in access to care to our patients. From an oncology care first, I'm happy that they pushed back 12 months for 2022. We may need more time, but we'll see how this plays out. I'm not convinced that vaccines will be available that quickly, like in January or February, maybe April, March, who knows, of 2021. It will probably take 3 to 4 months or so to have a significant number of us vaccinated. And it's said that maybe 50% of us in America may choose not to get vaccinated, which is more complicated. So what I'm saying here, that we're far from being close to the end of the tunnel here in terms of COVID-19. So I would hope that our commercial payers and CMMIs, CMS, look at us and look at these models with flexibility, so that we're able to do things properly without putting extra risk to the practices and as it relates to access of care. So hopefully we can continue to work together productively in a conducive manner.